In the shorter term, honestly, if we can just get better systems for doing implementation and evaluation of AI, that would be a huge, huge win. We're still suffering from really a lack of AI systems that are well vetted, evaluated, have shown proven, outcomes for patients.
This is the Visible Voices podcast. I'm your host, Dr. Resa E. Lewis. Audience, we are in the era of AI in healthcare. To that end, this is an episode where we're making the voice of AI in healthcare visible. Joining me in this journey is Dr. Andrew Taylor. Andrew is an AI researcher and an emergency medicine physician. He's a professor and vice chair of research and innovation in emergency medicine at the University of Virginia. He and his team develop AI solutions that are not only technically robust, but also ethically grounded, user-centered, and clinically implementable. I invited Andrew after reviewing a few articles that he and team published in journals such as New England Journal of Medicine AI, Academic Emergency Medicine, and Annals of Emergency Medicine. Andrew, welcome to the Visible Voices podcast.
Thanks, Resa. It's great to be here.
You and I are connected through emergency medicine and through point-of-care ultrasound. You did training in New Haven at Yale in point-of-care ultrasound. From there, though, you have now developed work as a researcher and also specifically informatics and AI. Can you tell us a little bit about that professional journey?
Yeah, sure. So definitely started out in ultrasound. And I think I caught the research bug even very early on in kind of the ultrasound space. But I think the conversion for me to go into informatics, data science, and AI was around 2012. And some kind of listeners may remember this is around the time that there was a group from Toronto that started to publish stuff around computer vision. And they had significant performance kind of improvements over traditional kind of computer vision. And I started looking at it from the perspective of what can we do from an ultrasound and how can we look at that and can we automate aspects of ultrasound? And so that's one of the things that kind of got me into starting to do research about machine learning, AI, how can I get into the space and everything else. I did some other kind of classwork and everything else. And then that was also simultaneously the same time where our electronic health records we were getting our electronic health record. And I realized that there's going to be this mountain of kind of data that's going to be out there. And it's really nice to be able to kind of work with that from a research perspective. So that's what started the kind of journey, and it's continues ever since.
Does that put you on the early adopter curve?
I think so, but then if you look back at the history of AI, it's really, people have been using the term AI since the 1950s. So it's hard to say you're an early adopter when it's gone through a couple of decades, and there have been what they call AI winters over a few period of times. But I definitely think from a healthcare perspective, I would call myself in the modern era an early adopter.
I love this. I recently had a conversation with Dr. Christian Rose, and he said what you said, that actually AI has been around and there have been 3 eras. So this is the newest era. So we are designating Dr. Andrew Taylor as an early adopter in the recent era after the long winter. So 30,000 foot view, it seems like AI tools are available, but they're not quite really well established or doing as well as we know they can do in hospitals yet.
Yeah, some of this I think is around hospital infrastructure and personnel. So I think it's hard. You really need to have, a fairly large team to be able to do AI development and to do implementation of AI. And then you need to have the right infrastructure. And that has really changed, I think, with a lot of these large language models that people are mostly going to be familiar with, calling it ChatGPT or something, or Gemini or something like that. They are very computationally resource heavy. And so a lot of traditional kind of hospital infrastructure is not going to really have that in place. And then the other aspect of that is still, I think, the kind of lack of openness of electronic health records. And that's been a persistent problem for many years. And I think if you look into other industries like business and everything else, there's very rapidly have adopted a lot of these tools, and it's still taking time in the healthcare space.
If I can share, there was a landmark article it was around 1999, 2000, that talked about technology that is quickly implemented and taken to by other industries is not the same speed and cadence for healthcare. And this is exactly what you said. Healthcare is so slow to change, even with proven efficacy, proven patient safety. The numbers I've read is like 10 to 15 to 20 years before change occurs. So it's unsurprising that things are so slow. And to your point, hospitals are very kind of complicated machines and built environments. So things are slow to change.
Yeah, definitely.
Yeah. So you and I are emergency medicine physicians. A lot of the work that you've done has been looking at processes in the emergency department. We're going to break this up for listeners who may not be in healthcare, who may not be in emergency medicine, but certainly they've seen the shows on television. The emergency department is chaotic. Emergency physicians and other healthcare workers have to move quickly sometimes and make quick decisions. And also, because of ED crowding, long boarding times, sicker patients, there's been a PIT model, a provider in triage, we'll say a physician in triage model. And recently I was doing some work and some writing on the use of ultrasound in triage and why haven't we moved the ultrasound machine to triage. You and your team have done some work looking at decision making and bias in triage. And I love this work for many, many reasons. Number one, there's bias that we see when we're working in the emergency department. It's very disturbing. And I think it actually causes quite a bit of moral injury for those of us working. And when you have data on which you're working, like the vital signs, how a person looks, humans, there's bias that occurs. So one of the first publications that caught my eye that made me say to myself, I really want to speak with Andrew, is something that was a letter in Annals of Emergency Medicine, but then became a publication in the New England Journal of Medicine AI. The title of that was Impact of Artificial Intelligence-Based Triage Decision Support on Emergency Department Care. At the end of the day, when patients get triaged, and probably you've all been triaged, we are seeking to identify the sickest, the people that need to be emergently seen. You and authors write, our objective was to examine the impact of implementing an AI-informed ED triage tool on triage performance and patient flow. Tell us more.
So I think one thing for the listeners probably to understand is like that triage system, the traditional kind of system is this 1 through 5 kind of point scale that has been done. And that point scale is somewhat based on acuity of the patient. So do they have vital sign abnormalities? How bad do they look? Do you think they're having a heart attack? And then some of it is based upon resource allocation. Like, do you feel like you're going to need a chest x-ray or have an IV line or stuff like that? And while that's like, I think fairly well kind of tied into some of those aspects, it's really not based on any kind of objective outcomes. And so one way to kind of get around that is to do machine learning and AI to train it on something that you may be interested in that's going to happen downstream from that for patients. And so this algorithm is trained on the fact that is the patient going to be admitted to the hospital? Are they going to have an emergent surgery? Are they going to go to the ICU within the first 24 hours? So that gives you some kind of context on how it's identifying the acuity of the patient. The real, like a big motivating factor around this, though, is this aspect that, okay, we have this 1 through 5 scale, but most patients get grouped into this big level 3. So 1 would be patients that need to be immediately seen. They're having heart attacks or strokes. 5 are patients that are coming in for medication refills or things like that. And then you have this group in the middle that are 3, and they tend to stack up because everybody kind of lumps them together. They don't have, exactly vital sign abnormalities, and they may be going to use a few resources. So this algorithm is really designed to better distribute those acuity kind of scores across the 1 through 5 scale. And then just to give you, give listeners kind of a perspective on what it looks like for nurse, because the nurse is traditionally applying this kind of triage score or acuity scale. So that the AI algorithm will present a score. It's the same, like 1 through 5 scale. And then it provides some information about how that recommendation is being made. Does the patient have significant vital sign abnormalities? Do they have a past medical history that would kind of make them more risky? And then the nurse gets to make a decision about whether they feel like they agree with that score or they feel like, oh no, I think like this patient should have a different score. So that's presented at triage. And then you see kind of what happens downstream.
So I love the way you've framed this. And I'm just going to summarize. Patients that seem not as sick and are not as sick get a higher score, like a 4 or a 5. Patients that are super sick and, as Andrew highlighted, need to be seen right away, we think are going to need an ICU level of care, will be admitted to the hospital, may need an emergent surgery, they get a 1 or a 2. And to your point, there would be this big, big lump of people that are given a 3. I will say when I worked triage shifts, there was a human bias. Like I thought that there was often a rush for me to see certain patients versus others. And I never did official study, but my concern was, did this relate to racial ethnic identity? Was there a difference with sex and gender? And I'm wondering what you found, because you looked at this and reported on this in your study.
Yeah, and so totally agree with that, and that's been my experience both anecdotally and working as well. So the I think the thing for the listeners to realize is like this AI is largely objective. It takes whatever vitals you have, whatever past medical history, and then the algorithm is previously trained, and it just will spit out the same result, at least the way that the algorithm that we have in place. And so what we saw when we implemented this was that there were shifts in some socio-demographic groups from better kind of allocation of their acuity score to their vital signs, to their past medical history, and what downstream kind of outcomes, those outcomes of emergent surgery and ICU. The short story is it looks like it promoted fairness within the system. And that's maybe a little counterintuitive to, I think, probably what a lot of listeners hear about AI is like, oh, we're worried about fairness, we're worried about bias. And I tend to lean a little bit on the other side and think that there's a real chance for it to really promote fairness and equity in the system.
And what I've read in terms of AI is good stuff and quality put in, good stuff and quality out. Junk put in, junk put out. So in programming, coding, in developing the AI tools, if it's done ethically, it's done in a human-centered design way, the ideal goal is that we get something quality out. There's something specific, and I'm wondering, Triage Go. Tell us about that.
Yeah, so Triage Go, and I should state this. So it's the initial algorithm was developed by a company, actually it was Stochastic. It came out of Johns Hopkins and then developed into Triage Go at Beckman Coulter. And so that's the algorithm that we've kind of been describing. And the clinical decision support that's around that. So the algorithm is just making the prediction about these downstream things, but then the clinical decision support is how does that look to the nurse when the information is being displayed, kind of in what types of kind of decisions can be made off of that.
Does that integrate with the electronic health record?
It does. So it is like directly in the nursing workflow and their triage nursing workflow. So where they would traditionally go down and put a score for the ESI score and the triage score, it's just right there. And so all they have to do is just either override it or accept it as the actual triage score.
And what did you and co-investigators find in terms of how this AI tool worked?
So what we're seeing with this is that more appropriate people that are higher acuity, so have these bad outcomes, are getting placed into the right category, so the ones and twos. And then those people that were lumped in the threes, so that middle group that were of lower acuity get shifted into these fours and fives categories, so the lower. And what that means long term is that people are getting placed into the right buckets. And then that means they get placed or get seen at their more appropriate times within the emergency department. A lot of times also to recognize is that like emergency departments sometimes are subdivided. So they maybe have like a, lower acuity section, and it does matter. If a patient that's high acuity has issues going on, gets placed in a low acuity, they may be treated differently because of that. And so it allocates that distribution a lot better. And then because of those types of things, then we see changes in downstream outcomes. Like there's some acceleration in the operations moving through, like how fast patients move through the system, better kind of treatment along some conditions, like cardiac conditions was one area we saw some improvements.
What did you find in terms of human assigned score versus AI assigned score in terms of men and women?
Yeah, so the scores themselves, across those distributions, those were fairly, I think, okay when it came to like the distributions of like sex or men and women. What we did see some along race where the scores where we had that kind of shift to improved, what I would say, fairness or performance within the system along racial categories. And
yeah.
So what we saw was that for the patients with a Black race, that there was a shift where their vital signs, were they're more appropriately aligned in those categories. So they looked sicker and everything else. And then there was a shift on the lower acuity side where they started to better align with those lower acuities. So their vital signs improved. They had less comorbidities and everything else. What that means is that prior to the tool, there were patients that were being placed in the high acuity areas that weren't necessarily high acuity, and that were being placed in the low acuity areas that weren't necessarily low acuity. And so you want better kind of distribution or allocation across those.
Yeah, more accurate assignment of their acuity level so that they get to the right place sooner. So I want to move to another emergency department publication, and this was in Academic Emergency Medicine. The title, Leveraging Artificial Intelligence to Reduce Diagnostic Errors in Emergency Medicine, Challenges, Opportunities, and Future Directions. So again, listeners, for all of you that have ever watched ER TV programs, be it The Pit, be it ER, be it fill in the St. Elsewhere, I'm dating myself, and you have a sense of what it is like in the emergency department. And in reality, you probably have had your own experience, or family members, friends have had experiences in emergency departments. It is chaotic. There's a lot of cognitive load and decision making that occurs for all healthcare team members, certainly emergency physicians. So this was a thick, robust piece that you and co-authors wrote.
And so the basic idea is that most people function in a system one where there's a lot of kind of rote, either memorized or very kind of procedural aspects to their decision making. And the best way I can explain it from an emergency medicine context would be for like a patient with chest pain. When they present, they're sweating, they're clutching at their chest or something like that. We have seen enough examples of those types of things to know, oh, that person is sick. You have this kind of exemplar in your head. You don't really have to think much at all. There's no analytic processing, and you just, move on through that. So it's a lot very heuristic based. And then there's this second kind of type of thinking where you need to do a lot of deliberative kind of rational thinking, weighing risk and benefits and all of those things. So those two kind of processes are there in place. And a lot of people now think, we switch back and forth between them on a fairly kind of regular basis. And AI can help, and I would say more broadly, like data science can help in both of those areas. So, and that's kind of what we discuss within the article. Is like, I tend to like to characterize it as like decision hygiene, like how the decision environment, that the place kind of where we make decisions. And as you mentioned, like emergency medicine and the emergency department is a really bad place for that. It's super chaotic, fast, it's loud, all of those things.
I was going to say, what I really like is you and authors actually give a hat tip to even what it's like to be the human working in the emergency department. Like, we may not be fed, may not be rested, we may have been working a 12-hour shift and we're at hour 11 of that 12-hour shift. So there's a lot of human factors. So how do you and authors start looking at clinical decision systems and making better clinical decisions?
Yeah, and maybe I'll tie this back into the triage, because I would say one of the things, probably the most frequent question or ask from us from that paper that was in the New England Journal of AI was, okay, are you going to do a study that looks at this kind of human AI part and how people are like the disagreements that were made between the nursing staff and the AI and what factors were contributing to that? And the answer is yes. And I think it really highlights like all of those kind of issues that you're alluding to. And our hypothesis is, that nurses may make very different decisions from when they start their kind of triage shift versus when they're at the end and they're tired, whether it's nighttime versus daytime, whether it's around, whether they've been fed or not. So I think that those things start kind of like to contribute, and you can start to analyze those things. So we're going to be able to do that with the kind of triage. But all of those things kind of factor into this kind of decisional kind of noise that gets kind of put into the system. Hopefully AI can help in kind of smoothing out all that variance that can happen because we are humans and we kind of fluctuate in all these different ways. By doing assistance with some of these decisions makings, but a lot of it also is, can we present information better? So I talked about that kind of system one, like what is the kind of stuff that just we intuitively see and then we were able to make a decision? It's like, can we present people's past medical history better or their medications in a better way so that like I can just look a lot quicker and then make a decision off of that?
three things that you highlight: improving available information to make a decision, which is what you just said, supporting information synthesis with the clinical decision support, and finally, facilitating education feedback with quality improvement.
Right. And so, yeah, definitely on that first one, like making kind of those visual displays of information a lot better. And then I think AI probably from the traditional kind of AI that we think about is probably most recognized in that second, where we're taking all of these factors, people's past medical issue, the medications, other things, and then taking that together and then training it to make some type of decision. So in Triage, it was emergency outcomes, but it can be anything from like, a diagnosis, prognosis for the patient moving forward. And so it allows kind of that synthesis. And then the last one, and this is the area that I'm very interested in right now, is like we've traditionally had this model where we don't get a lot of feedback on the diagnoses that we make. And a lot of it is just because of the resources within the healthcare system. We don't have the ability to capture all of the kind of potential diagnostic errors in the system. And we don't have a way to then screen them further and then provide that feedback to physicians. And so AI can assist to kind of look through all of these mountains of data and then get that back to teams so that we can start to learn better from kind of the mistakes and other things that are happening within the system.
Listeners can probably imagine, like, the electronic health record. In one way, it makes things so much easier and so much faster, but another way, it actually is like this diversified portfolio of so many places to look. So I was super interested by the paper that you talked about the attending physician, the physician in charge, if the model is an academic medical center, that the amount of time that a faculty member looks in doing chart review, because again, listeners, you may understand, when we have a patient in front of us in the present, all the past tests, all the past hospital visits, all the notes from all the different specialists that they may see as an outpatient, all that is there. And so it's often quite a task to collate all of that information. And I really loved that AI ideally is going to help with presenting the most relevant, cogent synopsis of all that past stuff in the EHR.
Yeah, and I think a lot of people, if you've started to use some of these kind of chat LLM tools like ChatGPT and other, you've probably seen this in a different space. Like you've read an article or you've dropped in a very long, like, policy document or something like that, and then asked it to do a summarization or get out the salient points. So you can think about that, the same thing in the healthcare space. So I have a patient that comes in with chest pain, and there are certain pieces of information that I want to know about that patient. It's like, when did they last see their cardiologist? Did they have a particular cath on a particular time? When was their last EKG? But as you just mentioned, like it takes time to find all of that information and collate it and bring it together. And I think there's a real opportunity for AI to like synthesize that information and then give it to us so that we can then kind of rapidly make a decision and not miss pieces of information.
Yeah. What do you think is next, and what gives you the most optimism right now regarding AI in healthcare?
Yeah, I mean, I would say if you looked in the business space, there's a huge movement. And AI moves very, very quickly, but there's a big movement towards what's called like AI agents. So these are largely kind of autonomous, more goal-driven AI systems. So the example I'll give you is that you can prompt like a kind of a chatbot that you would typically see, and you can ask it, build me a website with these particular features. And under the hood, what the AI agent is doing is that it's going out and it's figuring out, okay, these are the things I need to know about a website. This is potential code. I'm going to pull that and information, and then I'm going to start to run the code. If I run into an error, then I'm going to change the code based on the errors, and then I'm going to continue to kind of iterate off of that until I reach a particular goal of like having. So that is it's a very different paradigm, because it's very goal oriented than what we have traditionally done in AI. And I think we're going to see those systems come into the medical space. Probably not, again, like going back to the infrastructure things, they're heavy on needs for infrastructure. So I don't think it will be, the next year or two, but I think we're going to see those downstream. And what that allows you to be able to do is like, you have a patient with now you ask the AI agent, I want you to better manage this patient's diabetic care within the system. And it will then know that, okay, I need to go and send out a consult for this person, or I can need to look at these particular labs and I can potentially adjust these medications. And that's probably where we're headed. I think in the shorter term, honestly, if we can just get better systems for doing implementation and evaluation of AI, that would be a huge, huge win. We're still suffering from really a lack of like AI systems that are well vetted, evaluated, have shown proven, outcomes for patients.
For people that are interested in getting more involved in AI in healthcare as a part of their professional journey, what would you recommend?
So yeah, I think there's a couple of avenues. Probably what I would not recommend is going to a course. I know that's really tough because people want like certificates or they want to say that they've taken a course. But again, the field moves so quickly right now that it can, you can take a course and it will be outdated in 6 months to a year. So some of it is getting plugged into just different streams. There's a couple of different like email systems that will send out like updates to all of these kind of chatbots that are coming out and new things that are being found. And because it's hard to manage, like it's even hard to manage for me, like just to keep up with a lot of things that are going on out there. But there's really good content that's being produced online in various spaces. There are short lecture series and things like that. So yeah, I think it's hard to like point to a single kind of source, but
I love
they're
what you
out
shared because, there's a flash and it's a super expensive price usually to get the next course AI in healthcare. And, I think that the small nuggets of ongoing learning on a regular basis is going to serve people better than the go for a course that and pay thousands of dollars.
Right, because what you need is to be able to have like speak the language and to understand when people are talking about a particular concept or propose like some solution that is involving AI. And so to some degree, the really nice thing about the movement of AI is that it's becoming more and more abstracted away from like the computer programming. So I tell a lot of my students honestly now is that I'm not sure that you're going to be really programming in 2 or 3 years because AI is doing a lot. But the nice thing is that you can then start to think about like being an AI engineer and working with all these different AI systems and creating like really amazing solutions in shorter periods of time. And so having the kind of vocabulary and the kind of conceptual layer is, I think, more important than probably the real like nuts and bolts of the mathematics or the computer science at this point.
Andrew, I'm so appreciative that you joined me in this conversation on AI and healthcare on the Visible Voices podcast. For listeners and watchers and audience members who want to follow you in your work, what's the best way to follow along?
I would say probably LinkedIn is probably the best place for my visibility. Otherwise, I'm not great with social medias. But yeah, you can definitely reach out that way.
The Visible Voices podcast amplifies voices in the healthcare, equity, and current trend spaces. Our team includes Dr. Giuliano DePortu and me, Dr. Resa E. Lewis. Find me at Resa E. Lewis, MD on social media or visit the website, thevisiblevoicespodcast.com. Please give us a 5-star rating on Apple or wherever you listen to podcasts. Be sure to subscribe, watch, and listen on YouTube and share the show with a friend because together we're making healthcare more equitable, one visible voice at a time. This podcast is for education and entertainment purposes only. The views and opinions expressed by our hosts and guests are their own and do not necessarily reflect the opinions of their institutions. Information shared here should never substitute for clinical judgment or for medical advice.